Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Tarafder Shahniam Ahmed, Associate Professor of Pharmacology, Bashundhara Ad-din Medical College, South Keraniganj, Dhaka. Dear students, welcome to my fourth episode of lecture describing drugs acting on sympathetic nervous system. In previous class, we have discussed the pharmacological effects of sympathomimetics on different tissues and organs. Today we shall discuss about few individual drugs, their uses and an account of short note regarding them. Let us start with adrenaline. Adrenaline is a natural catecholamine. It has actions both on alpha and beta receptors. It is given by parenteral route. It is added to local anesthetic drugs to prolong their actions, and it is also used as a topical mydriatric. It is useful in shock because of its actions on the cardiovascular system, the airways and blood glucose level. Regarding the dosing of adrenaline, you are often asked in professional exam oral questions that what is the dose or what is the strength of adrenaline. The next slide is showing you the strength, how we serial dilute the strength of adrenaline and which dose is used for shock. Injection adrenaline 1:1000 strength is given intravenously slowly every 3 minutes until his or her vital signs are felt or vital signs are regained. Noradrenaline is also a natural catecholamine. It is given by parenteral route. It acts mainly on alpha 1 receptor of arterioles and raises the peripheral vascular resistance. It has some stimulant effect on beta 1 receptor of the heart and causes tachycardia. But you should know that this tachycardia is always compensated by reflex bradycardia, and noradrenaline is also useful in case of shock. What about dopamine? It is a very important question in case of your written examination as well as in oral examination. The dosing and effects of dopamine in cardiogenic shock. Please note that in low dose, dopamine stimulates the DA1 receptor and leads to renal vasodilation, thus improve renal blood flow and increase the glomerular filtration rate. So, it is popularly used in cardiovascular shock or cardiogenic shock. In moderate dose, it stimulates the beta 1 receptor of the heart muscles, leading to increased heart rate and increased force of contraction, thereby increased cardiac output and increased systolic blood pressure. When we raise this dose a slightly more higher level, the stimulation is done to alpha 1 receptors of the peripheral smooth muscles of arterioles and increase diastolic blood pressure. We also use isoprotonil clinically. Isoprotonil has a strong stimulant action on the heart and increase heart rate and force of contraction. It has a very negligible vasoconstricting action. It is mainly used for complete heart block and very occasionally for cardiogenic shock. The next slide is showing another familiar drug, Dobutamine. Dobutamine is a synthetic analog of dopamine. It is very short acting. In low dose, it stimulates the D1 receptor of the central nervous system, renal and other vascular beds and improve tissue perfusion. At dose is raised, it activates the beta 1 receptor of the heart similar to dopamine and increases its positive inotropic effect, thereby force of contraction. It seldom acts on the heart rate. When given by IV infusion, it increases renal blood flow. The next slide is showing description about ephedrine. Ephedrine is a non-catecholamine and therefore, it is not metabolized by catechol O methyltransferase in the liver. It is a natural plant alkaloid. It is given orally, but also may be given by parenteral route. It differs from adrenaline in having a slower onset of action and prolonged duration of action. It is useful for bronchodilation and as mydriatric. Priapism or painful penile erection may be treated with ephedrine, and it also causes tachyphylaxis or rapid tolerance. We use some drugs as nasal decongestants such as phenylephrine and xylometazoline. You will notice that these drugs are commonly used in daily life during winter season. Phenylephrine has action similar to noradrenaline, but acts for a longer period. Ischemic damage to mucosa is possible if they are used too frequently, that is more than 3 hourly. Oily drops and spray from these drugs may enter the lung and cause lipoid pneumonia. As we have discussed during our introductory lecture, you have already come to know the role of alpha 2 receptors. Alpha 2 receptors are located presynaptically and involved in the autoregulation of sympathetic discharge. These receptors mediate the reduction of release of neurotransmitter, for example, noradrenaline and acetylcholine. Thus, the receptors provide a negative feedback and therefore, it control transmitter release. There are few drugs which are alpha 2 receptor agonists such as clonidine. Clonidine is structurally or chemically a imidazoline compound. These drugs suppresses sympathetic outflow and reduces blood pressure. Its abrupt withdrawal can cause rebound hypertension, so must be withdrawn in a tapering dose or gradual phenomenon or in a gradual manner. In low dose, the drug may be used for migraine prophylaxis. The next slide shows the mechanism of alpha methyl dopa in a flow chart. Alpha methyl dopa is converted to alpha methyl noradrenaline, which is released as a false neurotransmitter and acts by two pathways. In its central action, alpha 2 agonist, which is alpha methyl dopa, it causes auto inhibition of noradrenaline release, and so blood pressure is decreased. On the other hand, in peripheral action, weak alpha 1 agonist, that is methyl dopa, acts as an weak alpha 1 agonist, but strong alpha 2 agonist, and both these actions decreases the blood pressure. So, we have discussed very few drugs regarding this sympathomimetic chapter. This is actually the last class of this chapter. In the next class, we shall start drugs acting as adrenoceptor antagonists or blockers. Till then, thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.